Welcome, everyone. So first, a little bit about Crossover. We're excited here to talk about the employer value of measurement-based mental health care. Crossover is a national medical group. We help employers deliver foundational primary health to their members. We call it primary health because this includes a multidisciplinary integrated team, primary care and nursing, of course, but in addition, physical therapy and chiropractic for physical medicine. We have health coaching. We have care navigation embedded to steer patients where they need to go. And last, but of course not least, mental health, which is what we're going to be talking about today. And we deliver all these in what we call a measurement-based model that allows us to ladder up to value-based care in a way that fee-for-service just cannot. So I'm excited to talk to you guys today. My name is Daniel Lord. I'm the Central Region Medical Director for Crossover. I also oversee a lot of the programming of our care model. And I'm joined here with our mental health program manager, Michael Boroff. Michael?
Yeah, hi everybody. I'm Michael Boroff. I'm the mental health program manager for Crossover. I'm a licensed psychologist, licensed for about 12 years, and prior to Crossover worked for Kaiser and a few different government systems. And I'm here because I want to transform the way healthcare works and mental health care works.
Thank you, Michael, and welcome again, everyone. Really excited to dive into this super important mental health topic. And we have the right person talking to us. Michael, you're an expert. And so let me just start off with a question to you. What are you seeing as far as trends in the mental health landscape right now?
Yeah, I mean, it's been exciting. I think, with the pandemic, I think it's spurred a lot of innovation, and there's obviously a lot of venture capital money flowing into mental health solutions of all different kinds right now. So there's just a huge focus on it, both in terms of development, employer focus. There's not an employer we speak to who doesn't say like mental health is their number one concern right now. And so it's there's just a lot of interest in it, which I think is really positive.
What are your biggest concerns about the mental health landscape right now? What keeps you up at night?
I think there are a couple of things. One, nobody's really managed to scale mental health services in a way that works for everybody involved, for patients, providers, payers. We're trying to chart new ground here, and it's hard. It really is. So I think a lot about that. And then I think the other piece is I'm just worried we're just committing the same mistakes we've made in the past, and so much of what's happening in innovation and mental health involves the siloing of mental health off of the rest of the healthcare field, and that's a little crazy making to me that we're doing this again. I think if we were to step back and actually imagine what an ideal healthcare system would look like, it probably wouldn't be that, and yet that's what we're doing, and I'm not a fan of that.
Okay, so flipping the coin, what gives you optimism? What are some of the things you're seeing today that give you a good perspective on our future in mental health?
Yeah, I think, as I mentioned, there's just so much more of a focus on it. It's not something just off in the shadows that nobody will talk about, or need to whisper about. There's so much more transparency around mental health.
Astigmatism, right?
There's far less stigma, which is great, and I think young folks in particular are far more assertive in seeking out mental health services, being proactive around it, which is really fantastic. So I think that's a huge plus. I think even the way some of our employer partners, the things they're doing. We have one client who has a "How are you really" campaign where they're really trying to embrace vulnerability in the workplace and having these amazing brown bags and just really talking about mental health in a way that I think really opens things up for their employees. And just seeing people do things like that, I just love.
Yep. It's interesting because we've decreased the stigmatism. We've made it front and center. Employers are super focused on it yet. But the real challenges of mental health are the same: access and quality. If anything, it's made it almost worse. And so I want to dive in with you and kind of talk through, how do we make this better? So maybe talk about the first kind of concept here, relationship-based versus not transactional. How does that apply to mental health?
Yeah, it's really interesting. I think we have a national provider shortage already of therapists, and there it seems like there's never enough demand, or enough supply to meet demand. People are trying to solve for that in all sorts of different ways. But I think the thing that we really need to remember is when we look at outcome studies and what really impacts whether or not people get better, it's the relationship with the provider. We have so many the research has been replicated over and over again. And so when we talk about pulling the provider out of care, that really worries me, and I question how effective
Yeah.
that's going to be.
What do you mean by that, though? Pulling provider out of care? Maybe talk to that a little bit more.
Yeah, I think there are a lot of kind of computerized CBT solutions. It's almost like self-help, but with technology that is being touted. Even AI, which is still, I think, it's in its early stages, where people are basically trying to use tech to replace providers, and in the end, that relationship is still really important. Most people who seek out mental health services want to be heard,
Right.
seen, validated before they're going to do any of these interventions that we want them to do.
So Michael, that kind of sounds like you're a little bit against technology, though. What do you really mean by that?
Yeah, I think my first thought is, how can technology help therapists be more efficient, not burn out, provide better care to their members? That's my first thought about technology. And then the second is, there are people where those solutions work. And we just need to make sure the right people are being steered towards those solutions, that it's not a one solution fits all type of a thing. And that we're only sending people there when we know they can be effective in that type of treatment.
Right. That makes sense. That makes sense. Okay. The other key thing, not one size fits all, right? And I think you can speak to this, but it seems to me when I talk to employers, some of the clients I work with, a generic mental health solution, you just can't fit a round peg in a square hole. You need tailored solutions, right?
Yeah, I think mental health is so complex, and where people are in their journeys around seeking mental health services can vary so much. And so I think having um, being able to create a treatment plan that actually meets people where they are, something that they're willing to engage in, becomes really, really important. And so having a menu of options available to kind of make that happen becomes really, really important. I think what's challenging, and I certainly see a lot of our employers do it, they have these amazing kind of benefit offerings with so many different solutions. I think the challenge then becomes, how do people know where to start, and who's kind of guiding them towards the one that is
They're offering
correct
more
for them?
solutions than ever before. It's not always helpful.
Yeah, I mean, I really admire the spirit behind it. It's like, hey, mental health is a concern. Let's grab this solution. Let's grab that solution. But I think people don't know what to make of their health benefits when they're simple. When you talk to the average person about their healthcare, they don't even really know. And certainly where to access mental health services, that becomes hard as well. And so the more options you put out there, I think sometimes the more overwhelming and confusing it can get. I think it becomes really important to have somebody, again, who can do that guiding toward the correct resource.
We think about somebody who is going through a mental health issue. Their bandwidth to filter all of this stuff cannot be that big, right? Like, you have to make it really easy and simple for someone.
Yeah.
Right.
And I think there have been different attempts by employers and payers to make that happen, try to have one easy front door for it. I think we just have to think about who the right front door is, for guiding people towards that correct solution.
Right. You might have the answer to that question later in the talk, correct?
Sure.
Okay, great. I'll come back to you on that one.
Of course you will.
One of the key problems to solve in mental health is access, right? Try going out into the community today, anywhere in the country. And, the first patient or the first visit you're going to see is not the next day or the next week. And, in addition to that, try to access somebody that has a really high quality, or finding someone with high quality. It's a huge problem. So, Michael, maybe speak to this and how crossover is addressing access.
Yeah, and I think this is what I hear a lot of employers talk about first and foremost is we need access for our people. There's a secret shopper study done on a major payers panel, and they uh, they called a number of therapists on the panel to inquire about appointments, and 75% of the people they called weren't taking new appointments. Another 15% didn't have any for at least a month. And so it's just becomes so hard when you're calling a list from payers trying to find a therapist, and either you're not getting calls back or they don't have any availability. It's
And or
really
maybe it's
hard.
like you need a specific type of therapist that delivers certain types of therapy, and then it becomes even harder.
Exactly. And so we saw, when we did our white paper on our outcomes and looking at the research, the average time in the community, and this depends on which study you look at, but it's about 48 days on average to get to a therapist in the community, which if you're struggling with depression or anxiety, or you just had a major breakup or a loss, waiting over a month and a half to see a therapist is just not okay.
Mm-mm.
And so we've really, I think keeping access steady at Crossover is a huge focus of what I do. Our average time to see a therapist is 6.6 days. When people are on our virtual platform, they get a response from a therapist within 30 minutes to an hour. They're already talking to a therapist. And I think that's so important. When people are ready to take that step and get help, we don't want barriers in the way. We want help for them right away.
Right.
Yeah.
So that leads me maybe into the next slide. And I'll ask you, Michael, well, why is it that Crossover can provide access? What are we doing differently that others can learn from or work with us on?
Yeah, it's a great question. Yeah, I think there are a few things that we do. I think one is that we frame treatment in a certain way from the beginning, which is, hey, it's wonderful to have a therapist to talk to on a regular basis and have that outlet. But we want treatment to be really kind of goal focused, skill focused. We want you to develop a sense of independence and autonomy. And we want to build that system of support around you in your life, away from us as well.
Yep.
And then we're tracking outcomes all the way along the line. And you mentioned measurement-based care. Sometimes in mental health, it gets called feedback-informed care, feedback-informed treatment. And the idea with this is that our members are regularly providing feedback via our outcomes tool to our therapists around not just their symptoms, not just PHQ and GAD, but also how they're functioning, their relationships, and also their relationship with their therapist. And we that talked about a little bit above, the importance of relationship in mental health care. We know, shocker, when the alignment is strong between therapist and patient, the outcomes are better. And when we actually ask about the relationship, it helps us course correct in the middle of treatment. It actually helps us adjust when things aren't working in a much more proactive way. A lot of people say they do measurement-based care, but all they're doing is like a PHQ at the beginning of treatment and a PHQ at the end. That's not measurement-based care.
Right.
Measurement-based care is allowing you to take in that feedback and shift throughout treatment. When you do that, treatment is much more efficient. People get better faster. They have a better experience of therapy, and it actually frees up access for the next person who needs it.
I'd love to double click one more time on this, because I think feedback informed care is also unique in that it's hard to practice and deliver fee for service. Where feedback informed care is most successful is in a value-based model. How do you, Michael, look at your entire book of business, your whole program, all the therapists on your team versus individual therapists? Like, how do you set those benchmarks? And when you talk about therapeutic alliance, like, what do you mean? Is who's involved in therapeutic alliance? How do therapists know that score, and what happens when there's a bad score?
Yeah, it's a lot of questions. Let me work through them.
Mike, let's go. Go, Michael.
Yeah, I mean, I think the first thing you hit on that I think is important is fee for service, just as it is in all other aspects of healthcare, is problematic in mental health care. It incentivizes therapists to keep people in care too long and creates cogs. So I part of Crossover is But whereas we talk about doing healthcare the way it should be, we want to get rid of fee for service and not practice that way. It's really, really problematic. We want people in care who need it, who are benefiting from it, and when they don't need us, we want them to be able to move on and know that they can always come back. Therapeutic Alliance, you asked about that. Every session, our members complete the survey about their symptoms and their therapeutic alliance with their provider. And so those questions involve, hey, are we talking about what's most important to you? Do you feel like I understand and respect you? And do you agree with the way that we're going about your treatment? And those scores give the therapist feedback about what's happening and whether or not they need to course correct. And our therapists, when that happens, when they get a lower score, and our patients are often very kind to us. Sometimes I'll have a really great relationship with somebody and I'm getting perfect scores. And then all of a sudden it drops just 1 point. And it turns out that I suggested something the last session that their last 3 therapists have suggested too. They don't like it. They didn't know how to tell me in session. That's a way for them to actually bring that up and address it with me. And so really powerful conversations get to come out of that. And as a therapist, my responsibility is to be humble and curious and not upset when they give me that feedback. And oftentimes that's the fear that our patients worry that they're going to upset us in some way. It's just like, no, I'm here to be helpful to you. That's my job. And if I'm not being helpful, I want to know about it so that we can shift. And so all of our therapists talk to the patients in the very first session about this. Like, hey, I know these might be hard questions to answer. Please, I need you to answer them honestly so that we can provide you with the best care possible.
I appreciate that. And that's what it's all about. Sometimes it is about those hard conversations. And so the relationship that we make and the measurement that we deliver just allows us to practice differently. I'm glad that you're able to talk through that. So let's talk about how we actually track our progress. Michael, do you want to speak to some of these outcomes?
Yeah, I think, what we noticed, and I mentioned this before, measurement-based care is a place where mental health has lagged way behind the rest of the healthcare industry. When we looked at it, only 14% of mental health providers regularly use progress measures. 62% have never used them. And I certainly see this. I interview a lot of our prospective therapists, and so few people come in having done this. So it's a place that we're really lagging behind, and it's problematic. How can we improve something we're not measuring? Yeah.
And well, you're not incentivized to measure if you're just charging fee for service, cash or insurance. You're not incentivized to actually get the patient better, which is kind of funny.
Yep.
Okay. How about here?
Yeah, and so it's an expectation of all of our therapists that they use our outcome measure Tritium, and so 100% of our providers are using it regularly. Our members can always refuse to do it. That's certainly their choice, but we do have conversations with them about, again, it's there to benefit them. This isn't utilization review where once you hit a certain score, you're out or anything like that. It really is about tracking progress, making sure that people are in fact getting better. And the beautiful thing about it is that those kind of graduations from treatment happen organically. It's like, oh, wow, like you've been under 25 on the Tritium score for 4 sessions in a row. Like, look at all the work you've done. This is where you are. How are you feeling about it? It just creates that conversation naturally, which is what we want.
Yep. No, thank you. That's awesome.
And this is a look at our outcomes. Tritium, our outcome tool, has this really great metric called BHI, Behavioral Health Index. And it incorporates not just depression and anxiety, but also subjective emotional well-being and functioning. And in the end, what we want is people to feel better and function better. Tritium actually measures that for us. So that's what this BHI score is. And when we looked at how we're faring compared to community samples that are comparable to who Crossover works with, we see an average of about a 30% decline in that BHI score. It's a 0 to 100. So seeing really significant changes in it. The average community sample saw about a 10% decline over the same time range we looked at it. And so our providers really are generating fantastic outcomes in our model, which feels really good.
How does this really quickly, how does this change behavior of the providers, right? Because in order to actually have access and hit the triple aim and have this improvement, they also have to buy into this new model.
They do. And I think, one of the things the data does is just help them not make assumptions about what's happening. I think a lot of times we're actually not the best predictors of how treatment is going. And data helps us focus on it and realize, oh, wow, yeah, I've seen this person 4 or 5 times, their score is not changing much. The treatment plan really does need to shift. Something's not working. It really helps to, keep that front and center for our therapists as they're working with people. And that's hugely important.
Yeah. The other hugely important thing, and this is close to my heart and why, why I work at Crossover is it's integrated, right? All of our services, whether it's physical therapy or the care navigator or the mental health provider, we are shoulder to shoulder with the physician. We meet every single morning, talk about patients, talk about our population, talk about our metrics, look at our BHI scores and understand how to improve our panel. I'd love to talk a little bit more, Michael. I'd like you to talk a little bit more about why is this so important for mental health? Like, where's the magic there?
Yeah, I really get a little bit baffled as to why we want to continue to try and separate the brain, the mind from the rest of the body as if they were separate, independent things. I I I don't understand. And we know that what happens psychologically impacts the body. And many people who have kind of chronic mental health conditions also develop chronic medical conditions and vice versa. Mental health issues don't exist in a vacuum, but we continue to try and approach treatment as if they did. And so I'm just a huge believer in integrated care. I'm here for a reason. I was Kaiser for a reason. Built an integrated care clinic for homeless folks for a reason. These things all tie together, and the best care comes when there's a team of people treating a whole person together. When the primary care doc can say, hey, it sounds like your stress level is really high. I'm noticing your anxiety score is high. We have therapists right here that specialize in this. This one is fantastic. I think would be a great fit for you. Let's get you scheduled. Or even pull the provider into the room to meet the person for a few minutes. That's huge. That just
and discuss medications and discuss the plan with the provider and the patient as a team. I mean,
yeah,
it's significant.
it is. And when we have to refer out for medication management, we do the best we can to find providers in the community that will work with us and communicate with us. But it's so different than when they're part of our own care team. Yeah. When we can actually communicate with them about, hey, this person says the side effects are a little bit strong on this medication. Can we shift the dose? It's just so much easier. A lot of times they're sitting right across from us at the table, the primary care doc who's doing the prescribing, and it just works so differently. Even, I so often am like prescribing exercise as part of behavioral activation and treatment of depression. Look at somebody with knee pain. It's like, hey, let's get you scheduled to see this physical therapist and address your knee pain so that you can actually do this part of your treatment plan. Yeah. It's just all right there. The other piece that I think is really important, we talked about stigma. It still does exist, and in some communities at much larger levels. Yeah, I think integrated care is huge for helping destigmatize mental health services when it's right there and treated as part of a normal healthcare experience. It helps open the door to people who might otherwise not seek it out.
Yeah, and I think about the variability of mental health in the community, where if you're getting referred from your physician into an evidence-informed, evidence-based model that's measuring your outcomes. I mean, the experience is significantly different. So
it is, and there's so many people get lost. When they get referred outside of the walls of the primary care, they so many don't make it. They just never follow through with that referral, and then they're not getting the help they need, and that's a problem.
Yeah. Is it true 70% of primary care visits stem from psychosocial issues?
Yeah, depending on the population we're looking at, up to 70% of primary care visits can involve psychosocial issues. It's a really great paper that was just released from the AMA, American Medical Association, about using technology to improve the integration of behavioral health into primary care.
Yep.
And this is one of their points, that, hey, primary care is inundated with this on a daily basis. And again, why are we siloing behavioral health, mental health away when this is where this is the front door for most people? And
they point blank made that recommendation as part of the paper.
They did. It's really a nice paper. For those of you who haven't looked at it, we can link it out as well. But it actually talks about how the different players can impact this, including employers. And one of the recommendations for employers is to have a whole person kind of primary health model that has care navigation and destigmatizes mental health services, which is exactly what we do.
Yep. And we see this in our practice, right?
Absolutely. Yeah. When we looked at ours, 1 in 10 seen in primary care diagnosed with depression and or anxiety. And we have, I think, generally speaking, a little bit of a healthier population than the population at large. We're seeing about 4 in 10 are reporting some significant symptoms of depression or anxiety in the general public right now.
Yep. I'd love to go into some specific examples, right? Because we're talking about high level data. But I love this example because this patient walks into crossover all the time. And we see patients with chronic low back pain that have a huge mental component to their pain, or chronic disease management where mental health is required in order to solve or improve their diabetes numbers, in order for them to take action. There's that integrated approach makes a huge difference. But Michael, I'll let you talk about this one in particular.
Yeah, I think this is the type of patient we see all the time, eating healthy, exercising, but couldn't get rid of chronic neck pain. Normally, this is somebody who would go right for an expensive imaging. In this case, they saw a physical medicine specialist with us first. Provider actually worked with them and actually picked up on the fact that, hey, there's an emotional component here, and let's work with one of our in-house mental health specialists around the kind of the psychological pain that's informing your neck pain. And so something I've seen so often in other care organizations where this is somebody who either gets opioids or what we're really medicating is psychological pain.
Yeah, that's accurate, Michael. That is true in the community right now. We actually prescribe 10 times less opioids than when compared to the community, and that's published in JOEM. But this is why, because we have this team approach, and we can actually get people to the appropriate conservative care faster in this model. So no, thanks for talking through that. Before we dive into Q&A, any last points, Michael, that you wanted to bring up?
I think one of the things I would say is that I love my job because at Crossover, I get to ask myself why all the time. Why do we do things the way we do? If we're going to fix things, we actually need to start to question the ways we've always done them and ask ourselves, are these things working? And I think for mental health care in particular, there's a huge need for all of us, and all of us are playing a role, the employers, the payers, Crossover. We have to really think about, why do we do mental health the way that we do? Why is it paid for in the way that it is? Why does it exist in the benefit ecosystem in the way that it does? Really ask ourselves these questions and think about, hey, how can we do this better? And it's a question I think about every day, and will continue to, and hope that the attendees and people who watch this are asking themselves that as well.
Yeah. Yep. I feel the same way, Michael. How are these structured? What are the needs of your members? Is there a measurement-based perspective? Is there an integrated team? Are there outcomes that you can attach the value and quality of your service to? Because a lot of times those questions are unanswered today. And so definitely want to leave people with those questions. And then let's dive into some of these extra questions that we got from the audience here. I'm going to look. Okay, so one of the first questions, How frequently are crossover patients able to see their patients?
So in therapy, it varies depending on what's appropriate for the treatment plan. We have some folks who are seen every week, especially initially as treatment plans are established. I would say the average space between sessions is 2 to 3 weeks. So that would be normal.
And maybe what happens in between visits, Michael? Is it just silence on the airway and then see you next visit, or how does that work?
No, we really want people working on skills between sessions. Even if they're seeing us weekly, it's 45 minutes and the rest of the time is theirs. And so we have things that we have them working on, skills. We have some fantastic treatment manuals that have worksheets and things that they can address in between sessions so that they're working on getting better.
And just chatting, right? Like the quick chat messaging communication that happens is invaluable.
Yeah, I really appreciate it where in between sessions, patients shoot me a message, hey, I got into another argument with my wife. This is what happened. Can you offer me perspective? And instead of scheduling another session, I just take 5 minutes and respond, give them some feedback, and it's helpful.
I think it's really important because it's a hybrid, right? It's not just visits and it's not just asynchronous chat messaging. It's a combination of both, using content at the right place at the right time. Next question, does it make sense to continue to bundle your mental health with your EAP partner?
Yeah, I mentioned asking myself why all the time. And this is one that I'd really love employers to ask themselves, why are we doing this? I've given some answers around it, but it's this weird thing like, okay, I have a physical health issue, I call my doctor, but if I have a mental health issue, I call this completely separate entity that's going to handle the billing of it differently, authorizations, all of these different. I don't always understand why we're doing that. And often what EAPs do is they just have kind of networks of people they're contracted with. They don't really have any quality controls or overarching philosophies or approach to care. They're not measuring outcomes. And to be frank, in this current market, therapists have more options than they've ever had before. And EAPs typically don't pay very well. And so if you're a good therapist, you have choices. I always worry a little bit about the quality that happens in those EAPs. So it's a place where I would really encourage employers to maybe rethink the way that they're structuring their benefits and think about other ways to do this.
You're speaking almost to the next question that I see here. Is there a set of solutions for mental health benefit employers that they need to have in place, that employers need to have in place? Like, is an EAP alongside coaching and other solutions appropriate? What are the key solutions, would you say?
Yeah, I would argue that an integrated primary health model is the beginning solution, that ideally is who's the kind of the quarterback, and you can have other solutions in your ecosystem, whether that be a computerized tool or a discount to Headspace or Calm or one of the meditation apps, things like that, coaching. You can have those offshoots, but I think it's so important to have the primary care home be the facilitator of getting people to the option that works for them. And so I'm just a big believer that that's the best approach as a front door.
That's great. So what role do self-guided apps and AI have in addressing mental health demand challenges? Because you guys, the partner, I don't want to name names, but there are partnerships with apps and other tools that you guys use within your treatment plans. But how should people think about this?
Yeah, I think as I said a little bit earlier, there's a role for these innovations. I think we just have to make sure the right people are getting to them. If there's somebody who is super motivated and they just want the skills and the relationship isn't as important to them, so a computerized CBT app may be the best solution for them, and we can help them get to that.
How do you identify that though? Like, it's nice, easy to speak to that, but how do you guys actually identify those individuals and then get them there?
Yeah, so we always want to start with an assessment with an actual provider. If what's going on, and then once we've had that assessment, we want to present options to people and say, hey, these are the things that we could do to approach the challenges you have. what are you interested in? Okay, here are the pros and cons regarding this. If somebody wanted to do something like a computerized CBT app, how confident do you feel that you could stick with it? We know that 80% of people drop off of those within 10 days of starting them. They just, most people don't stick with them. So do we need to outreach? Do we want to set up check-ins every few weeks where you can tell me about how it's going, or shooting me a message to let me know how it's going? We want to actually help you be successful in this and not just disappear. You're here for a reason. Let's get you help. So I think it really is just about matching the person to what is going to work for them.
Awesome. Thank you, Michael. Thanks everyone for joining. I think we are over now, so we will wrap this up. Thanks for listening, and hopefully you guys learn some more tools and strategies for your mental health strategy. So thank you very much, Michael.
And I think we have some questions just to leave people with too, Dan, on the final slides. And just some things to leave you with, whether you're watching this live or recorded. I always just, when things like this pop up, I always encourage people to have a commitment that they're taking out of it, so that it stays fresh. And, think about your mental health care benefits. Do you know how well they're serving your organization and your employees? And there's some follow-up questions to this on the next slide. Does the structure provide opportunities for employees to build relationships with their providers? Do you know if your employees are actually getting better? What are the outcome metrics? And is your mental health care offering integrated with your primary care model? All really important questions to ask yourself. Always amazing to me, as Dan mentioned, how few mental health solutions actually report out outcomes, good and bad. And we try to be really humble with ours. Mental health care is hard. We want to report what we're doing well, and where we're not, we want to partner with our employer partners to figure out how to do better.
Awesome. Well, thank you everyone so much. Please connect with us at connect@crossoverhealth.com if you have any follow-up questions. We would love to help you.